Hello everyone, at this session we are always privileged to serve you. Today we are looking at quantification of malaria parasites using thick and thin smear stained with Gimusa stain, which is a form of Romano whiskey stain. Previously we looked at the video on how to identify different species of Plasmodium, that is P. falciparum, Plasmodium malariae, P. vivax, and P. ovale. So in this session we are going to see how can we quantify to know if someone has mild malaria or moderate or severe malaria. And as we begin, if it is your first time, please subscribe, like the video, and share to many others. So we are looking at quantification where we are talking about both thick and thin film. And this slide of mine has both films, whereby this one is what we are calling thick film, then this one is thin. Thick film is used to detect the presence of malaria parasite. This one detects the presence, then this one is used to identify the species. To identify, or you can call it to type or classify, if it is either P. malariae, P. vivax, P. ovale, or P. noresi. So there are different species we can detect their presence using thick. Why do we use thick film? Because it is thick, it increases the chances of identifying even parasites in low parasitemia. Then after identifying and after detecting their presence, we can go ahead to use a thin film to identify or to characterize the type. And we have said we stain these ones using the best stain is, or Roman whiskey stain is Gimusa stain. So after making these smears and they are dry, what you do, you mount the slide on microscope. After mounting the slide, you use high powers, that is times 10 and times 40 objective lens. What are you looking for? You're looking for the quality of the smear, the distribution, so that you identify the area 1 centimeter from the tail end where red cells are evenly distributed or they are not overlapping. And that area we call it zone of morphology. Zone of morphology, where RBCs are well distributed. Then you can even use times 40 to rule out presence of large parasites like microfilaria, like trypanosomes, so that you can see them under times 10 and times 40. So we begin with times 10 and times 40 to look at the quality of the smear, to look for the presence of large hemoparasites, then to look at the distribution so that we can get area where cells are evenly distributed, and we can even use it to identify white blood cell differential count, to know if there is neutrophilia, eosinophilia, or lymphocytosis. So after doing that, we are now looking at, we swing now to times 100 objective, and times 100 objective, after adding oil immersion, we use it to look for the morphologies, further to study the detailed morphology of different parasites, if they are present, and the presence of inclusions in red cells. So under times 100, that's where we want to quantify our parasites. And the first method we are using is the plus notation. And this plus notation is not the best method. This one is not the best. Why? Because it depends on the thickness of the smear. And we use this one on thick films. We use it on thick films, not thin. And why are we saying it is not accurate? Because it depends on the thickness of the smear. If the smear is too thick, you get more parasites. If it is not thick, you get less parasites. So not recommended or not being accurate. Yes, we are using it routinely because it saves time, but is not the best to use for quantification. And how do we determine? Here we use times 100 objective oil immersion, and we count in the zone of morphology, or we count from a thick film, either using battlement method, whereby you can move up, then across, counting parasites, you move down, you move across, you move upwards, and this method we are calling it battlement method of counting. So you count how many parasites per field. When you move in this field, how many parasites you move, how many parasites, how many parasites. If you get 1 to 10 malaria parasites, here you record it. This is per, you count up to 100 fields. We count up to 100 fields. So you use the battlement method, you keep counting until you reach 100 fields and tell us how many parasites have you seen. If you see 1 to 10 malaria parasites per 100 fields, here we don't call it high power. High power field is not recommended because times 100 is not a high power field. So it is better you say per 100 fields. So when you see this one implies a +1. Then if you get between 11 to 100 malaria parasites per 100 fields, here it is a +2. Then if you get 1 to 10 malaria parasites, this is per field. Every field you count in, you get between this 1 to 10 parasites, each field having malaria. This one is a +3. It implies there is high paristemia. Then if you get greater than 10 malaria parasites per field, this one is a +4. That is when you're getting greater than 10. So meaning here, it is showing very severe paristemia. So this is how we can use plus notation, though we have said it is not accurate because it depends on the thickness of the smear. So this is how we can report. Is the easiest way to use, but not very accurate. And it is done on thick films, majorly. So after doing this, now we are going to look at how can we determine parasite density. And this parasite density, I want you to first note that we approximate that per microliter of blood, it is approximated to have 8,000 white blood cells. So when we are using a thick, that is when we are using a thick smear, we approximate that 1 microliter of blood has 8,000 white blood cells. So what we do using a battlement method, we are going to count concurrently, we are going to count the number of white BCs. At the same time, we count the number of malaria parasites. So if we count malaria parasites and they become greater or equal to 100 parasites, here we stop at 200. Here we stop at 200 white blood cells. But if you count and the malaria parasites are less or equal to 99 malaria parasites, here you continue up to 500 white blood cells. So this is the rule we are applying when we are using this method, the parasite density. If you count greater or equal to 100 malaria parasites already, here you stop at 200 white blood cells. But if you count less than 99 malaria parasites, here you count until you reach 500 white blood cells. And the formula for calculating this we are going to say that parasite density or number of parasites per microliter of blood is equal to number of malaria parasites counted over total white blood cell counted, then times the average number of white bloods per microliter of blood, which is 80,000. This is in per microliter of blood. So the results are recorded in per microliter of blood. So for example, if I'm counting, then I get maybe 200 malaria parasites, and because they are greater than 100, we stop at 200 white blood cells. Then I multiply by the average number of white blood cells per microliter. I'm able to get, I'm see 200 going with 200. I remain with 8,000 malaria parasites per microliter of blood. So this is how I record my results. If I get less than 100, I continue up to 500. That is the rule we have used here. But the quick check, or if you are in the lab, you don't have time to calculate in this way, because this formula is the WHO recommended, we can use a factor whereby if we are counting and we are using 200, if you get 8,000 divided by 200 white BCs, you get a factor of 40. So you can always, if you are using 200 white BCs, you count the number of parasites and you multiply it by 40. And if you continue to 500, if I get 8,000 divided by 500, I'm able to get 16. So 16 become a multiple when I'm using 500 white BC. But when I'm using 200 white BC, the multiple becomes 40. So you will find some literature not showing you this formula, but though this is the most recommended, but they are saying number of parasites times 40 when you're using 200 white BCs, or number of parasites counted times 16 when you're using 500 white blood cells. So that one is a multiple factor we get from this formula, but it is recommended to use this formula, which is recommended, not the shortcut. But in the lab, you can use this shortcut to get results faster so that you can report to the patient. So this is the way we can determine using thick smear. Now let us look at when we are using thin smear. When we are using a thin film, as we said, thin films are to identify. So here you shall record about the species, the stage, and the size. And always remember, whenever you see gametocytes, those are the sexual forms, you report them separately. So among all methods of quantification, gametocytes are reported differently. You report the trophozoites and schizoids alone, those are the asexual forms, and then the sexual forms also separately. So never count them together. That is what I want you to note. So under thin smear, here the first note is that 1 microliter of blood is approximated to have 5 million RBCs. That is the first thing you must note, that per microliter of blood, we approximate to have 5 million red blood cells. So here what we do, we count the total number of RBCs. We also count the total number of parasites. So what we do, we count at least 20 fields is the one we count, and each field is approximated to have 250 RBCs. So if I get 20 times 250, I get 5,000 RBCs. So for high paristemia, you can count up to 5,000 RBCs. Then you also look at the number of parasites present. So those are the at least 20 fields we are talking about. So the formula we use here is that the number of parasites, or the parasites, is equal to the number of parasites counted divided by the total RBC counted times 5 million, which is the approximate number of RBCs per microliter of blood. This is the standard formula which is WHO recommended. So, for example, if I have counted 100 malaria parasites, and the total RBC count maybe is approximated to be 5,000. So the number of malaria parasites, if I substitute in this formula, I get 100 divided by 5,000, which is the total RBC counted, times 5 million. These ones go with this, by 5, then this is 20. We end up getting 100, because 20 times 5, that is 100,000. You get 100,000 parasites per microliter of blood. But remember, it is a thin film. And we said under thin film, you have to type the species and the stage. And we said gametocytes are reported separately. So what we do, on the number of parasites, we shall report that it is 100,000 parasites is 100,000 Plasmodium falciparum trophozoids. That is, I'm assuming if it was P. falciparum, trophozoids per microliter of blood. So this is how we report. You report the species and the trophos and the stage. If it was schizont, you can say maybe Plasmodium malariae schizonts per microliter of blood. So you make sure you identify the species and the stage, and in case there is also pigments in the white blood cells, you can report them, and also the gametocytes separately. And in case you have not, like for example here, if you don't see any parasite after counting 100 fields, you report no parasite found. No parasite found. That's how we report. But for the areas which we suspect to have P. malariae, you don't stop on 100 fields, you can even go up to 200, so that you increase the chances of detecting the parasite. So this is the parasite density method. Lastly is the percentage paristemia, where we are looking at the number of the percentage of infected RBCs. So what we do, we count the parasiticized RBCs vis-a-vis the unparasiticized, those ones without the parasite. So you use a tally counter, or you can use a tally sheet, whereby one, you are counting for the red blood cells with the parasite, and also you count those without a parasite, then you get a total. And how do you get percentage paristemia? Percentage paristemia is equal to the number of parasiticized RBC out of the total RBC count, then times 100%. So, for example, if I have counted 50 parasites to have been 50 RBCs to have the malaria parasite, and the total number of the total number of RBC counted is 500, then I multiply by 100%. This one goes with this, and we get by 51 by 51, we get 10% of the infected RBCs. And this 10% is very high. If it is P. falciparum, the cutoff for it to be severe is greater than 5%. That is for P. falciparum. Then for P. malariae, greater than 1%. That is P. malariae. Then for P. vivax, for vivax and ovary, that is greater than 2%, we consider them to have high paristemia. So these are the ways we can use it. And what are the complications of high paristemia? One of them is thrombocytopenia. So you can perform a CBC to look at the platelets. Why do they go low? Because there is cytoadherence in the microvascular cells. So there is increased destruction of the platelets. Also, there is increased trigger of hemostasis, leading to low platelet count. So there is always, I want you to note that in hyperastemia, there are some complications like low platelet count. There is what we call renal failure. Renal failure still is due to the cytoadherence in the microvascular vessels of the kidney, of the glomerulus. So because the parasites and the free hemoglobin produced is toxic, they occlude or they adhere to the microvascular cells of the glomerulus, leading to hypoxia and lack of blood supply. So the kidney injury can result. So that is kidney failure. We can also see hypoglycemia and also cerebral damage, leading to convulsion. So these are some of the complications. So whenever someone has severe malaria, always do a CBC to rule out thrombocytopenia, always you do RFTs, renal function tests, do a glucose test, because these two can kill the patients very faster. And also, we can always see this by presence of convulsions and coma. So, and even me in the lab, when I'm doing a CBC, before I do a BS, I can always, and I see there is a thrombocytopenia and increase the percentage of neutrophils, I always suspect malaria. But it doesn't mean that every low platelet count is malaria. But in case you see low platelet count, always go ahead to do further tests to make sure it is not malaria. So this is what I can share with you about quantification of malaria parasites. Hope you guys have enjoyed. Please remember to like if you have enjoyed this video and share to many others. Thank you so much.